Hey guys, my name is Edwin Wayne. I'm a second-year radiology resident at Cook County Hospital. So our case is a mature ovarian teratoma. Our patient presentation is a 16-year-old female, no significant past medical history, presented after a MVC. Just giving some background of mature ovarian teratoma. So they're the most common type of germ cell neoplasm. Teratomas usually contain mature or immature tissue of germ cell. These germ cells are usually pluripotential. They contain various histologic types. So mature teratoma is the most common subtype of all teratomas, and they're a congenital neoplasm composed of tissues from at least two of the three germ cell layers. So the germ cell layers are endoderm, which turns into mucinous and ciliated epithelium, mesoderm, which turns into muscle and fat, and ectoderm, which turns into skin and brain. So most mature teratomas do not contain immature components, and the tissue subtypes are very well differentiated. So teratomas usually originate in the midline, usually occur in the sacrococcygeal region in children and the gonads in adults. So for just discussing some imaging findings for our patient is totally asymptomatic, and this is a incidental finding. So usually mature ovarian teratomas present as a cystic mass with distinct capsule. It usually contains internal sebaceous fluid that is most often uniocular. It characteristically contains components of fat, which can be seen up to 93% of cases, calcifications, which can be seen up to 56%, and floating soft tissue masses. So the presence of intratumoral fat is the most specific finding of a mature teratoma. Calcifications are usually secondary to teeth or bone, usually shown as coarse or linear calcifications. The Rokitansky nodule is considered the most common finding of a mature teratoma on ultrasound. It presents as a source of squamous epithelium and hair within teratomas. So pelvic MRI can be done for equivocal cases and is very sensitive for detecting fat, utilizing fat suppression sequences and chemical shift artifacts. So for our case, radiograph is initially done after patient presented. We can see there is a pretty heterogeneous calcification in the mid-pelvis. It's a pretty non-specific finding. And on coronal and axial CT, we can see there is a fairly large heterogeneous lesion in the right annexa, depicted by the red arrow. There's a distinctive capsule around this lesion. This lesion contains coarse internal calcifications, as seen with the green arrow, and also there are macroscopic fat density within the lesions shown on the blue arrow. So the imaging findings are fairly specific for a mature ovarian teratoma. So mature ovarian teratoma is the most common germ cell tumor, like we discussed a little earlier. Is the most common ovarian neoplasm removed at surgery. It is the most common ovarian mass in children. Numerous rare complications can arise from teratomas, including rupture, torsion, infection, malignant transformation, or hormone excretion, or stroma ovarii. Ruptured teratoma results in leakage of sebaceous content in the peritoneum and lead to chemical shift or peritonitis. Malignancy can arise from any of the three germ cell layers. Malignant transformation was reported at about 2 to 3% and is more common in children. Mature cystic teratoma are known to have slow growth rates, usually 1 to 2 millimeters per year. So non-surgical treatment is typical for most patients, and annual follow-up for lesion less than 7 centimeters is needed to monitor growth. Surgical resection is the primary treatment for larger lesions because teratoma can invade adjacent structures and usually are pretty well encapsulated, so surgical removal is fairly easy. Our patient was referred to a gynecologic clinic and treatment has yet been discussed. So that's all we have. Thank you so much for your time.